So next we're going to have Medical Network 1 present on their implementation. And we have Jessica Siewert and Carrie Coleman here today. So just 1 second to advance the slides. So Jessica is a registered dietitian, nutritionist, and certified diabetes care and education specialist with over 20 years of experience. She completed her Master of Public Health in 2020, enhancing her commitment to advancing health through empowerment, improvement, and understanding. She currently works for Medical Network 1 as a nutrition and diabetes care manager and serves as the MCT2D clinical lead for 3 physician practices. And Carrie Coleman is a registered nurse, complex care manager, and diabetes educator who provides face-to-face and telephonic care to multiple practices in Southeastern Michigan. She strives to improve patient outcomes via education, goal setting, and team collaboration with her practices. So I will hand it off to you.
Okay. Thank you for having us today.
So it's always fun to go second because you get to repeat everything that was just said. But we were one of the accelerated sites to work with MCT2D, and we had a fun time jumping in to the initiative. Luckily, as perhaps with all the accelerated sites, we already had some of the key things we needed for this initiative in place. So we had an existing care management program in the offices that are participating. We are lucky enough to be co-located in most of these practices. Some rely on using telephonic referral type things, but we have certified diabetes care and education specialists. I always trip over that because they had to go and make that certification name like twice as long as it needed to be. The registered dietitians, registered nurses. Unfortunately, at this point, we're kind of hurting when it comes to behavioral health or pharmacy staff members, but we already had people in place who could do all the pieces of the initiative. So the carbohydrate management, the CGM, the way to interpret those CGMs, the practices had accounts with the Dexcom Clarity, the LibreView, and we were prescribing medications regularly with a good relationship with some of our pharmaceutical reps. And we do have at all of the offices, we're supporting a good PA process. Already exist.
So a day in the life, so workflow process. Very simply for our care process, we get a referral or we go find that referral. We complete an encounter either face-to-face or telephonically. Some offices are set up easier for a telephonic service. Transportation was mentioned previously as being a barrier. So we do try to accommodate the patient and provide that education, care coordination. We follow up with the provider. We really want to close that loop. So we follow up with the provider, go over the plan of care, make the changes and adjustments that need to be made, and then follow back up with that patient, closing the loop. 90 days is typically our referral, follow up. However, some patients we found, especially if we're starting the CGM, they need a 2-week follow-up. They need a 1-month follow-up. So we really need to meet that patient where they're at.
So when it came to operationalizing these initiatives, the challenge for a lot of our practices is how do we take something that is kind of nebulous, good diabetes care, and make that something visible, make that something where there are certain steps to accomplish so that we know what it is we're doing. So one of the things that we've had to work on is building out some type of data so we can see what change has happened. So a lot of this is EMR work, and we work with independent physician practices. I think between us, Carrie and I can use 15, 18 different EMRs. to one
It's a
level
little bit
or another.
overwhelming.
Yeah, exactly. But as she mentioned, identifying those patients, sometimes we noticed if we sit back and wait for a physician to identify a patient, that provider is just busy going through their day. So we were looking for ways to see those diagnoses, to see whose A1C was over 8%, who could we target? How could we make those a panel of patients that we could track and follow over time? And then as well, we wanted to look and see what was it that we were doing with these patients. Some things are really hard to track. We might talk with a patient about carbohydrate management, but there's no real code that goes into a patient encounter that says that. So trying to make less of a manual process. So using procedure codes, some of the data that we were able to obtain came from some pharmacy feeds. We'll kind of talk about that in a minute. But I think knowing what resources you have to work with is pretty important. We have dedicated care management staff, but as you all know, there's a ton of initiatives out there. So carving out what time belongs to these new activities was a challenge. And then running reports, just so we could see on an interim basis what is happening, where are we going, what changes are occurring. So we mentioned a day in the life, that's kind of a typical workflow. Some of the changes that happened to that were, as I mentioned, looking for patients in a little bit different way, looking based on their diabetes diagnosis or their A1C. Proxy, that kind of gave us a hint on who was on what medications sometimes, because that's difficult to find unless you're doing a manual search for the charts, and ain't nobody got time for that. So
Jessica and I also have really been loving our relationship with our medical assistants. They're really boots on the ground. They are in tune with patient needs and sometimes see things more so than what we can see automatically. They can come and say, hey, I really have XYZ going on with this patient. I need your help with this. So those medical assistants we rely on for referrals for sure.
yeah. I think some other workflow changes just happened in that assessment and treatment phase. As it was mentioned in the last presentation, it's that collaboration and that coordination within the care team. It's circling back with that provider. It's asking the question of who is ever in charge of the prior auths, which in my practices are MAs. Where is this at? How can I help you?
Increased discussion of CGMs with patients has been much more comfortable for me after I wore one. We got the freestyle sample and I downloaded the app. I was able to use it and I felt much more comfortable talking to my patient and saying, hey, I wore it. I forgot it was there after 24 hours. I can really relate to how you might be a little bit nervous about trying this out, but I tried it. And if you don't feel comfortable with it, you can always take it off. And I think they kind of step back and think, well, I can try it. And then once they try it, they really fall in love with it. So definitely increasing that discussion has been really improved with my familiarity with CGMs.
Yeah. And then I know it was mentioned about, having those education materials available. So when we started out with MCT2D, the website was kind of that front page. And it was the front page. And so they're working to put together a lot more information and resources for us. But originally we had kind of gone, outside that spectrum to see what other resources, what education pieces we could leverage, whether it was from the nutrition care manual that dietitians often have access to, or whether it was some actually very nicely customized patient education pieces that we were able to create with one of our pharmaceutical reps. It was really looking to see how are we going to treat this thing a little bit differently.
Follow-up process change, what we're trying to focus on is face-to-face visits. The teach back is a lot easier face-to-face, I find, and I find more medication errors face-to-face. On the phone, a lot of them will say yes, 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 and they just want you off the phone sometimes. So in the office, I have them trapped a little bit, and they have to really explain to me how they're administering their GLP-1 or if they're titrating up on their Trulicity, et cetera. So definitely in-person visits. Again, we have those barriers with transportation, but we're really trying to focus on that for our workflow changes.
Yeah, and then callbacks when we can't get them back in the office. So when I put it into my EMR schedule, instead of complaint for the visit, flu or cough or whatever, I just put MCT2D. And we were asked to include a slide on carbohydrate management. This is one of the workflows where there's still some tension, I think, for implementing these, nutritional limbo, the kind of how low can you go question. And, from a perspective of our PO also runs the National Diabetes Prevention Program, and they use as standard a DASH diet with that. So according to the IOM categories, that would actually be considered a high carbohydrate diet. We have seen good success with that with our participants in decreasing A1Cs, weight loss, those kinds of things. So that's kind of been our standard of care. And I think provider comfort is part of that picture. And for me personally, I became a dietitian to feed people, and I have a background in eating disorders. So my passion is to provide the most healthful meal plan in the least restrictive way possible. And so I think there are some things that I'm looking forward to learning as part of the initiative as well.
So what's working through our workflow process? We've definitely had an increased number of scripts filled for target medications. Now that is just the data we could pull in a very, very small subset, and we'll talk about that in a minute. But definitely referrals through my provider. I work with a standalone provider, and he refers to me now to help titrate GLP-1s. And so that's been really beneficial, and it's taken some of the burden off of him. And we worked really together on that. And I think that's been quite successful. After the last regional meeting, I went back. I spoke with someone. She was talking about Freestyle Libre Rep. And I thought, I haven't reached out to mine in a while. I reached out to her. We had a face-to-face meeting. And out of that became a really good relationship with a DME supplier for Medicare patients. I told her I was really struggling. She said, well, I have the name of this representative. I reached out, and we work really closely together now. I have someone I can actually call and actually get a hold of if I have an issue with the CGM getting covered. And that was just by reaching out and really trying to form those network and connections. So definitely really good things coming out of this collaborative. Anecdotal reports of improved patient satisfaction. It's really hard to, really say exactly what these patients, how they're rating our success without the survey. So I just know that I have one patient in particular. We started him on CGM, and he also started on a SGLT2. And he came back and he was like, this is the best thing that's ever happened to me. I know what my sugar is anytime. He's like, let me check it for you. Let me check it for you. So every time he comes in, he checks it for me, and I download his data for him. He doesn't use the phone, he uses the meter. And I can provide all that data to the provider, and he just really loves it. He enjoys it. He can go up north and not worry about having lows. So So definitely, I've seen a lot of improvements in my patient satisfaction.
So she mentioned that we have seen an increase in use of the target medications that MCT2D is helping to advance. We were able to get some data. Now, unfortunately, it's very limited. We were only able to pull information from one payer product. It doesn't account for pharmacy benefit manager carve-outs. And it was just a limited amount. So I went 12 months back before the rollout of MCT2D for our baseline. And then the data after is from implementation year to date, which is technically April because of run out on claims. So one of our practices increased slightly, and so 7% to 34% there. Carrie's practice is really knocking it out of the park in the middle. We still have all the usual barriers to implementing the GLP-1s, patients who are afraid of needles. They think if they go on an injectable, they have bad diabetes, or just some of that shame-based feelings that people who have had diabetes for a long time sometimes have experienced in their care coverage as an issue. And then one of the things I found is, we're pretty good at figuring out where the coupons are and the copay cards and the patient assistance programs, and you get your cost of your GLP-1 for your patient down to $40. It's just $40, and they can do that. They go to the pharmacy and they have to pay another $50 to get the needles to use the medication. So there's some challenges there.
SGLT2, we've also seen an increase in prescriptions written. In my practice, it quadrupled. But it still remains lower than the GLP-1 usage, and definitely, but has increased higher than GLP-1. So I know we're on the right track, but still a long way to go. And definitely the data has been a little bit limited in this, but I've seen a lot of great improvements with SGLT2 and getting them prescribed and covered. That's the second part.
And I love the segue with the SGLT2s toward the nutrition counseling piece, because I'm always very careful to talk with my patients about water intake. And if you replace soda pop with water, you're doing a lot in the way of diabetes management. So one of the things we found as we were looking through this was that actually our use of CGMs tanked over the course of the initiative, which was not the direction we were wanting to go. But we found a couple of things were in the way of that. So we're problem solving with those. One of the big things though, Carrie.
Yeah, so I took those CPT codes and I was really excited about them. I gave them to the biller and I came back to her and I'm like, okay, so we're trying to get data for a presentation. Can you tell me how many CPT codes for CGM analysis have we billed? And she's like, oh yeah, none. Oh, okay. So that was really, that was my fault. I took them the information and didn't find out, how are you going to implement it? How is this going to change your workflow and how can I help you? I gave it to them and just walked away. So it's kind of embarrassing. I've talked about CGMs the whole time up here. Love them. Can't prove I've done one thing with them. So underbilling is a huge barrier.
Yeah, and I think that's in part, I don't know how everyone's care management system is set up, but our care management providers actually have a separate EMR from the practice providers. And that CGM interpretation code has to be billed by the physician. So it's jumping through these hoops of trying to figure out, where is this information going? Who is processing it? How are we counting it? So what we've learned is that we have some challenges. Of course, the best thing to do with your challenges is reframe them as opportunities. And so we have a lot of opportunities left when it comes to continuing to implement the MCT2D initiatives. We found that we're not always doing what we think we're doing. We started off in a really good place. We were an accelerated site. We were coming out and telling our practices, oh, this isn't going to be really hard. You do this work. And then they stopped doing the work. So we've found that we're underutilizing some of the resources that we do have. And that's not a good idea because everybody has limited resources. So we want to use those to the maximum. So increasing referral volumes to our care management team, being able to do some of those more advanced skill sets. If you have a diabetes educator, being able to titrate those medicines and other things that are at the top of the licensure can help ease workflows for some of the primary care providers. And then getting back onto some of the things we were doing well before. One of the challenges that was already talked about, challenges with staffing, challenges with COVID. You know, the MA in one of my practices that's solely dedicated to doing all the prior auths for the physicians also is working on the floor rooming patients and taking blood pressures. And so finding the time and getting the training so that everybody's comfortable, that rollout education for the providers, getting them excited and figuring out whose role is going to be what is key. So what we do want to do as well is figure out a way to measure what we're doing. You know, when you talk with a patient about weight loss, they step on the scale and they get a measure of what they're doing. And I don't know if you ladies feel this, but if it's a Monday and I'm down 2 pounds, woohoo, I'm good, you know, I'm motivated. And so being able to see some of these good numbers is really motivating, not just for the care management team, but also to take back to our providers and our practices and say, look what you've done, you know, and for the patients to come to us and say,
Absolutely.
you know, this is great. So working with that EMR, if I could give some advice for people who are just kind of starting out with this initiative, it's like, know how to put some of these things into your EMR and how to get some of these things back out of your EMR, because that's going to give you information on how you're improving, where else you can improve more, and give you that little pat on the back that you need when things get hard and you're on your 14th phone call trying to get a GLP-1 approved.
Leveraging resources. So we talked about really creating that network, drug representatives, product representatives, but also those medical assistants, everybody in the care team, involving them in the process.
Mm-hmm. Yeah. And then just looking at that data regularly, if we hadn't waited till June to pull the CGM report, we would probably be telling you how many CGMs we did, and the number would be bigger.
Correct.
So, everybody is always in the middle of a PDSA cycle, right? So those are some things that we've learned, and we appreciate everyone, you know, who's sharing with us in this journey. Thank you very much.
Thank you so much.
Thank you so much, Jessica and Carrie. That was a fantastic presentation. And we're so glad to hear that wearing the CGM was helpful for you and working with your patients. That was definitely one of our primary goals with providing CGMs.